Let's dive right in. Today, we're breaking down the essentials of pain management for nursing. We're going to cover the whole journey, from the basic science of how a pain signal travels all the way to the critical safety calls you'll be making at the bedside.
So, what if I told you that you could physically stop a pain signal from ever reaching the brain, and that you could do it with simple things like a massage or a cold pack? It sounds a little like science fiction, doesn't it? But it's a real physiological concept, and it's one you can use every single day. We're going to explore exactly how that works.
But first things first, before we can learn how to block pain, we really have to understand its journey. How does a stimulus, like stubbing your toe, actually transform from just a local injury into that sensation that we feel and perceive as pain?
Well, it all happens in 4 pretty predictable phases. First up, you've got transduction. Think of this as the initial spark. Some kind of tissue damage happens, which releases chemicals, and that triggers a pain impulse. Second is transmission. That impulse now has to travel up the nerve highway to the spinal cord and up into the brain. Third is perception, and this is the moment your brain actually processes that signal and goes, "Ouch, that's my toe." And finally, you have modulation. This is where the brain acts like a fire extinguisher, releasing its own natural painkillers like endorphins to try and quiet that signal down.
Okay, now this is where things can get a little counterintuitive. Take a look at how our body's autopilot, the autonomic nervous system, responds. For low to moderate pain, you get that classic fight or flight, sympathetic response. Heart rate, blood pressure, breathing, it all speeds up. But, and this is key, with severe, deep pain, the parasympathetic system can actually kick in, and you might see the total opposite. Heart rate and blood pressure can actually drop. The huge takeaway here, never ever assume a patient isn't in pain just because their vitals look normal or even low. The body adapts.
So knowing how that signal travels, how can we actually step in and intercept it? This brings us right back to that idea of closing the pain gate.
The gate control theory is just brilliant in its simplicity. Here's the deal. Pain signals travel on these small, kind of slow nerve fibers, but other sensations, like touch, pressure, and temperature, they travel on much larger, much faster fibers. So by activating those big, fast fibers, they essentially win the race to the spinal cord, shutting the gate and blocking those slower pain signals from ever getting through to the brain.
And here's how we put that amazing theory into practice every day. When you put a hot pack on a sore back, give a massage, or use a TENS unit, you are directly stimulating those large, fast nerve fibers. Heck, even distraction works on a similar principle by just flooding the brain with other sensory input. And remember, these aren't just comfort measures. You are physiologically blocking pain.
This idea of attacking pain from multiple angles is also the foundation of how we manage pain with medication today. It's called the multimodal approach. It just means we don't rely on one big, high-dose opioid. Instead, we combine smaller doses of different types of drugs, maybe an NSAID for inflammation, a local anesthetic to block a nerve, and a low-dose opioid. This actually gives better pain relief with a much, much lower risk of side effects. It's just smarter medicine.
Okay, let's switch gears and talk about opioids. Because anytime we use them, our #1 priority has to shift to safety. These are high-alert medications, and they demand our absolute vigilance.
If you remember one single thing from this entire explainer, make it this. This is the golden rule of opioid safety. Sedation always happens before respiratory depression. A patient will not just suddenly stop breathing out of the blue. They will first become increasingly sleepy and sedated. And what that means is your priority assessment isn't just counting their respiratory rate, it's assessing their level of consciousness.
And this is the tool you're going to use to measure it, the POS scale. Just look at the actions. Scores of S, 1 or 2, that's acceptable, you keep monitoring. But a score of 3, where the patient is drifting off in the middle of a conversation with you, that is unacceptable. You have to decrease the opioid dose and monitor them like a hawk. And a score of 4 is a flat-out emergency. You stop the opioid immediately. There is no gray area here. These actions are non-negotiable.
And the risks get even more specific with these advanced delivery systems. With a PCA pump, the biggest danger is something called PCA by proxy. That's when a well-meaning family member pushes the button for a sleeping patient, a huge no-no. For an epidural, the most catastrophic risk is an epidural hematoma, which is basically bleeding around the spinal cord. Your priority assessment has to be looking for that deadly combo of severe back pain with a sudden loss of feeling or movement.
Okay, let's apply this. Think about that POS scale. The patient can't even stay awake during a simple conversation. She briefly opens her eyes when you nudge her, but then she's right back out. That is a textbook POS 3. So, what's the priority? You have to intervene. The right answer is to decrease or stop the opioid and call the provider. Giving naloxone right now is probably too aggressive for a POS3, and just letting them sleep is ignoring the #1 warning sign of impending trouble.
You know, all of these interventions we've talked about, they rely on a solid foundation of good assessment and, just as importantly, patient advocacy. It's really about seeing the whole person, not just a number on a pain scale.
The PQRST framework is your go-to tool here. It pushes you beyond a simple number. You're asking, what makes it better or worse? What does it actually feel like? Where is it? When did it start? And, maybe most critically, the you. How does this pain affect you? What can't you do because of this pain? That focus on function is absolutely key.
And you have to match your assessment tool to your patient. For a typical adult, yeah, the number scale works fine. But for a little kid, the FACES scale with the pictures is way better. And for a patient with advanced dementia who can't speak for themselves, you absolutely must use a behavioral scale like the PAIN-AD. It is a dangerous myth that cognitively impaired patients don't feel pain. You just have to know how to look for it in their behavior.
Understanding the words on this slide is absolutely crucial if you want to be a good patient advocate. You have to know the difference. Tolerance and dependence, those are normal physiological adaptations to a medication. They are not the same thing as opioid use disorder, which is a pathological disease. And pay very close attention to that term pseudo-addiction. This is when a patient's behavior, like, say, going to multiple clinics, looks like addiction, but it's actually being driven by the desperation of having their pain undertreated.
So let's think through this last scenario. When you hear a colleague use the label drug seeker because a patient has been to multiple clinics, your first thought should not be addiction. Your first thought should be, is this person's pain being adequately treated? The most appropriate analysis here is that this behavior might be a sign of pseudo-addiction, driven by unrelenting, undertreated pain. Your job isn't to apply a dangerous label, it's to advocate for a better assessment.
All right, let's wrap this all up with a rapid-fire recap of the absolute must-know facts for your exams. Ready?
Here are your top 4 takeaways. 1. For patients with advanced dementia, you have to use the PAIN-AD scale. 2. Sedation always comes before respiratory depression, so you better be watching that POS score. 3. With PCA pumps, you never allow PCA by proxy. Only the patient pushes the button. And 4, with an epidural, that combo of sudden, severe back pain plus motor loss equals a hematoma emergency. Master these 4, and you'll be in great shape.
So, we'll end with this question. And this isn't just a test question. It's a real-world ethical challenge that you will face. When you hear that label, how will you reframe the conversation? How are you going to advocate for a comprehensive assessment instead of just a biased assumption? Answering that is really the core of what it means to manage pain effectively and compassionately